Hello, I'm Steven Pavletic, head of the graft-versus-host disease program at the Intramural National Cancer Institute in Bethesda, Maryland. We've been involved in GvHD studies for 2 decades and had an opportunity to watch the field evolving from an unknown disease and poorly defined to several, actually 4 recent FDA approvals for refractory chronic graft-versus-host disease. One of the big questions recently in clinical trials development and in advancing treatments for chronic graft-versus-host disease is how can we move advances and treatments faster and better forward for our patients. As we know, chronic graft-versus-host disease, although fairly common in allogeneic transplant patients, is a rare disease. And even among patients who do have chronic graft-versus-host disease, there's a huge heterogeneity relative to clinical manifestations, severity, organ involvements, many other numerous characteristics of transplant, the polypharmacy, and other challenges that we are facing with these patients. So a common question coming up is how the clinical trials that several of them recently led to the FDA regulatory approvals, how they relate to real-life situation. So the question and topic of our conversation today is how the clinical trials, particularly randomized clinical trials, relate and complement real-world evidence or real-world data. And actually, what do we mean when we say real-world evidence and real-world data? Randomized clinical trials is our gold standard, best proven research tool to prove the efficacy of a certain, typically novel clinical intervention in a disease. It's very well controlled, strictly controlled, observed very cautiously with a defined, as we know, eligibility criteria, response criteria, and other exclusion criteria, so we can increase our chances of providing an evidence that our therapeutic intervention actually made a difference in specific patient population. So it's a gold standard. It's has lots of internal validity, and it's really designed to support a hypothesis. However, there is a common problem with the clinical trials, specifically if you want randomized clinical trials, how it really applies to an individual patient. So we are able to detect effect, but how it really applies to an individual patient, how it can be generalized to general population of patients with a certain disease, now speaking about, for example, chronic graft-versus-host disease. And in this selected patient population, how are we able really to identify some other less common effects, whether some less common toxicities that can be identified, or how the results of this intervention apply really to patients with variety of clinical manifestations. This is why recently it's been increasingly an effort to conduct real-world evidence observational studies based on real-world data that, in contrast to randomized clinical trials, they're prospectively planned and rigorously monitored. The real-world data come from other sources. It comes from our daily practice. They come from patient records. Real-world data come from insurance companies' claims, observational databases, registries, and others. So the disadvantage of real-world evidence is that it's very commonly, usually it's done retrospective, although those studies could be done prospectively as well, but definitely less rigorously planned and have many limitations, such as wide heterogeneity of the patient population, difficult to reproduce, and so they have some disadvantages and advantages. In reality, real-world evidence and clinical trials are complementary. So the question comes up how those two are informing our clinical practice and how to interpret. Especially what do we do in situations where when a clinical trial shows a efficacy of a certain drug intervention, and when we move into real-world evidence, it's difficult to find. So the results are divergent and opposite. That poses major challenges, and it's one of the main criticisms of the real-world evidence. How to interpret? What should clinicians do when real-world data evidence don't support findings from the clinical trials? What do clinicians do if real-world evidence shows increased toxicity of certain or lesser efficacy of a certain agent that's in contrast with clinical trials? So these are questions that are inevitable, and everything comes down to interpreting totality of evidence and ultimately improving design of real-world evidence studies. Real-world evidence studies can be planned prospectively. This is why we talk more and more today about pragmatic clinical trials. So these are more strictly controlled clinical trials that are based in real-world evidence, but even randomizations are possible to be implemented in clinical practice. And there is increasing interest and need for using this real-world evidence data to support certain regulatory approvals. Real-world evidence data today, at today's stage, they cannot be accepted in general or as a rule almost to support regulatory approval of an agent. But there have been some cases, particularly in oncology, where real-world evidence would support expanding the label or complementing the clinical trials. When we talk about chronic graft-versus-host disease, this discussion is of special relevance to our field because it's a rare disease, it's very heterogeneous. We know there have been several prospective randomized phase 2 or phase 3 studies in chronic graft-versus-host disease recently that led to the approval of novel agents. They've been very supportive and indicative of therapeutic efficacy and safety in a refractory chronic graft-versus-host disease patient population. Currently, and I can use several of those examples. I'm not going to select one agent versus the other. We know there are several of those that have been recently FDA approved. Ibrutinib, ruxolitinib, belumosudil, axatilimab. Just to mention one example that in the situation of a drug, belumosudil, where we had actually personal experience in participating in some of these prospective trials, there, to my knowledge, at least 5 papers, publications being published as of today of real-world evidence in using this agent by itself or in combination with ruxolitinib or with some other best available therapy. And of interest, very consistently, all this real-world evidence turned out to be very helpful to our field, as I can interpret from my understanding, reading that literature. All of these studies have one in common, that they pointed in the direction of efficacy, although may not completely as up to the degree responses that have been observed in prospective studies, but they all point in the same direction of efficacy and safety of this agent in broad real-world patient population. What personally I find quite encouraging and informing our clinical care in a helpful way. I strongly urge practitioners and everybody else who tends to use real-world data to read those papers carefully and come up with their own conclusions. And what is really critical to keep in mind, that these two worlds are complementary. So real-world evidence and randomized clinical trials, they have, each of those have its role, and they can cross-inform each other, and it really turning out in a very helpful tool, both for advancing clinical research and informing our day-to-day patient care, as well as could be proven useful to informing funding agencies, third-party payers, and others. Thank you very much for your attention.